Welcome to this episode where we're diving into the complex world of pediatric gastrointestinal conditions. Today we're unpacking a broad spectrum, from developmental anatomy and nutritional disturbances to motility disorders, infections, inflammatory diseases, and critical hepatic conditions in children. It's a deep dive aimed at clinicians and specialists who manage these challenging cases.
Absolutely, Liam. The pediatric GI system isn't just a smaller version of the adult system. Its unique developmental features really shape how disease is present and how we manage them. So understanding these nuances is crucial for effective care.
Right. Let's start with the structure and development of the pediatric GI system. The GI tract begins forming quite early, around the 4th week of embryonic life, and continues maturing well into late gestation. This early development means congenital anomalies can be present at birth or shortly after.
And those developmental differences don't stop there. For example, the infant's mouth is highly vascular, making it a common entry point for infections. Plus, infants' natural tendency to explore their environment orally increases their risk of exposure to infectious agents.
Exactly. Another key point is the lower esophageal sphincter, or LES. Its muscle tone isn't fully developed until about 1 month of age, which explains why young infants often regurgitate after feedings. Thankfully, this usually resolves by the time they're 1 year old.
That's a great example of how developmental physiology influences clinical presentation. Also, stomach capacity changes dramatically, from about 10 to 20 milliliters in newborns to roughly 1,500 milliliters in adolescents. And by 6 months, gastric acid levels reach adult levels, which is important for digestion.
The liver is proportionally larger in newborns too, and pancreatic enzyme production matures postnatally, reaching adult levels by around 2 years of age. These factors influence not only digestion, but also susceptibility to certain diseases.
So, these developmental milestones really set the stage for how pediatric GI conditions manifest and how we approach treatment.
Moving on to nutritional disturbances, vitamin and mineral imbalances are a significant concern, even in developed countries. Vitamin D deficiency rickets, for example, remains an issue, especially among indigenous populations and children with limited sunlight exposure.
Right. Risk factors for vitamin D deficiency include exclusive breastfeeding without supplementation, dark skin pigmentation, living in northern latitudes, and cultural practices that involve covering the skin. These factors reduce vitamin D synthesis from sunlight.
And it's important to remember that fat-soluble vitamins A, D, E, and K have unique storage and toxicity profiles. Hypervitaminosis A and D can cause serious toxic effects, even at doses not far above the recommended dietary allowance.
Water-soluble vitamins like the B complex and vitamin C can also cause toxicity, but generally only at much higher doses. For instance, vitamin A deficiency manifests as night blindness, keratinization of epithelial tissues, and impaired immunity, while excess vitamin A can cause irritability, skin changes, hepatomegaly, and bone abnormalities.
Vitamin B complex deficiencies affect neurological, cardiovascular, and gastrointestinal systems, and excesses can lead to irritability and neuropathies. Vitamin C deficiency leads to scurvy characterized by bleeding gums, petechiae, and impaired wound healing, whereas excess vitamin C can cause diarrhea and kidney stones.
Minerals are just as critical. Iron deficiency anemia remains the most common mineral deficiency in children. Its absorption is influenced by dietary factors. Vitamin C enhances absorption, while phytates and tannins inhibit it.
Calcium and phosphorus balance is vital for bone health. Interestingly, whole cow's milk in infants can disrupt this balance, potentially leading to neonatal tetany. Zinc deficiency causes growth failure and immune dysfunction, but excess zinc can impair copper absorption.
That interplay between minerals is fascinating. Megadoses of one mineral can induce deficiencies of others by blocking absorption or competing for binding sites. So balanced supplementation is key.
Nursing care in this area involves thorough nutritional assessment, education on diet and supplementation, and monitoring for signs of deficiency or toxicity.
Speaking of balance, let's talk about body fluids and dehydration. Total body water varies with age and body composition, about 75% in term newborns, decreasing to roughly 45% in late adolescence.
The intracellular fluid and extracellular fluid compartments also differ in proportion between infants and older children. Maintenance fluid requirements are calculated based on weight and adjusted for disease states.
Dehydration is classified by serum sodium concentration into isotonic, hypotonic, and hypertonic types. Isotonic dehydration, the most common, involves equal loss of water and sodium and carries a risk of hypovolemic shock.
Hypotonic dehydration occurs when sodium loss exceeds water loss, leading to more severe clinical signs due to fluid shifts into cells. Hypertonic dehydration, where water loss exceeds sodium loss, is the most dangerous because rapid rehydration can cause cerebral edema.
Clinical assessment includes evaluating weight loss percentage, vital signs, mucous membranes, skin turgor, capillary refill, and neurological status. Weight loss is particularly important, but often challenging if pre-illness weight is unknown.
Management principles emphasize oral rehydration therapy for mild to moderate dehydration using commercially prepared oral rehydration solutions. Severe dehydration or inability to tolerate oral fluids requires intravenous fluid therapy, starting with isotonic fluids to restore circulating volume.
Potassium replacement is delayed until renal function is confirmed to avoid hyperkalemia, and rapid correction of hypertonic dehydration is contraindicated to prevent central pontine myelinolysis.
Nursing care focuses on meticulous monitoring of intake and output, vital signs, weight, and signs of fluid overload or electrolyte imbalance.
Now, disorders of motility often present as changes in stool frequency and consistency. The Bristol stool chart is a useful tool for objective assessment.
Diarrhea is a common symptom, often infectious in origin. Viruses like rotavirus and norovirus, bacteria such as E. coli, Salmonella, Shigella, and Campylobacter, and parasites all play roles.
Rotavirus remains a leading cause of severe diarrhea in children under 5, but vaccination has significantly reduced hospitalizations.
Management prioritizes fluid and electrolyte replacement, primarily via oral rehydration therapy. Antibiotics are reserved for specific bacterial infections, and anti-motility agents are generally contraindicated in children.
Early refeeding with a normal diet is encouraged to improve outcomes, which is a shift from older practices.
Chronic diarrhea may be due to malabsorption, food allergies, or chronic infections.
Constipation is defined by infrequent, hard, or painful stools, but frequency alone isn't diagnostic. Causes range from functional, which is most common, to organic, like Hirschsprung disease or hypothyroidism.
In infants, constipation is less common in breastfed babies. Formula changes can precipitate symptoms. Management includes dietary fiber and fluid optimization, bowel retraining, and laxatives like polyethylene glycol.
Hirschsprung disease is a congenital absence of ganglion cells in the distal bowel, leading to functional obstruction. It presents with delayed meconium passage, abdominal distension, and chronic constipation.
Diagnosis is confirmed by rectal biopsy showing aganglionosis. Surgical resection of the aganglionic segment, often via a pull-through procedure, is the mainstay of treatment.
Postoperative care includes anal dilations to prevent strictures and colostomy care if applicable.
Vomiting is a complex, centrally coordinated process with diverse etiologies. Bilious vomiting suggests obstruction, and forceful vomiting is classic in pyloric stenosis.
Management focuses on hydration and treating underlying causes. Antiemetics like ondansetron may be used cautiously.
Gastroesophageal reflux, or GER, is physiological, but GERD involves complications like esophagitis or failure to thrive.
The pathophysiology centers on transient LES relaxation. Management includes feeding modifications like thickened feeds and positioning, acid suppression with proton pump inhibitors or H2 blockers, and surgery, Nissen fundoplication, for severe cases.
Prone positioning reduces reflux episodes, but is contraindicated for sleep due to sudden infant death syndrome risk.
Shifting gears to food sensitivities and allergies. Food hypersensitivity includes immune-mediated allergies and non-immune intolerances.
IgE-mediated allergies can cause immediate reactions, including anaphylaxis, while non-IgE reactions are delayed and less severe.
Common allergens include milk, eggs, peanuts, wheat, soy, nuts, fish, and shellfish. Sensitization requires prior exposure with subsequent ingestion triggering stronger immune responses.
Food allergy prevalence is about 6% in young children, with many outgrowing milk and egg allergies by school age.
Early introduction of allergenic foods around 4 to 6 months in high-risk infants is now recommended to promote tolerance.
Diagnosis involves history, skin prick testing, serum IgE, and elimination challenge protocols.
Management centers on avoidance, emergency preparedness with epinephrine auto-injectors, and education.
Cow's milk allergy affects roughly 2.5% of infants, with 60% being IgE-mediated.
Symptoms range from gastrointestinal issues like diarrhea and vomiting to respiratory and dermatologic manifestations.
Diagnosis is clinical, supported by elimination and challenge testing. Treatment involves switching to extensively hydrolyzed or amino acid-based formulas. Soy is not recommended under 2 years.
Nursing care includes parental education, reassurance, and guidance on label reading to avoid hidden milk proteins.
Moving on to intestinal parasitic diseases. Giardiasis is caused by Giardia lamblia and is transmitted fecal-orally, often in daycare settings.
Symptoms include diarrhea, abdominal cramps, vomiting, and growth failure. Diagnosis is via stool antigen testing or microscopy, often requiring multiple samples.
Treatment includes metronidazole, tinidazole, or nitazoxanide. Prevention focuses on hygiene, sanitation, and avoiding contaminated water.
Enterobiasis, or pinworms, caused by Enterobius vermicularis, is highly contagious in crowded settings.
It presents with intense perianal itching, irritability, and sleep disturbances. Diagnosis is by the tape test collecting eggs from the perianal area.
Treatment with mebendazole or pyrantyl pamoate is standard, with all household members treated to prevent reinfection.
Nursing care emphasizes hygiene, environmental cleaning, and education to prevent recurrence.
Now, inflammatory disorders. Acute appendicitis is the most common emergency abdominal surgery in children, with peak incidence between 10 and 18 years.
Pathophysiology involves luminal obstruction, usually by fecalith or lymphoid hyperplasia, rarely parasites.
Clinical presentation includes periumbilical pain migrating to the right lower quadrant, fever, and vomiting. Perforation risk increases with delayed diagnosis, especially in young children.
Diagnosis relies on history, exam, labs like CDC and CRP, and imaging, ultrasound is preferred, with CT as the gold standard.
Treatment is appendectomy, often laparoscopic with antibiotics. Non-operative management is gaining traction in select cases.
Nursing care includes pain assessment, monitoring for peritonitis, and postoperative support.
Meckel diverticulum is a congenital remnant of the omphallomesenteric duct that may cause painless rectal bleeding or obstruction.
Diagnosis is via TECHNETIUM99M scan, and treatment is surgical resection.
Inflammatory bowel disease, or IBD, includes ulcerative colitis and Crohn's disease, both chronic inflammatory disorders with distinct features.
Ulcerative colitis involves continuous mucosal inflammation limited to the colon and rectum, with symptoms like bloody diarrhea and abdominal pain.
Crohn's disease is transmural, patchy inflammation anywhere in the GI tract, associated with fistulas, strictures, and growth delay.
Diagnosis involves endoscopy with biopsy, imaging, serology, and labs.
Treatment includes 5-aminosalicylates, corticosteroids, immunomodulators, biologics, nutritional support, and surgery.
Nutritional challenges include malabsorption, increased requirements, and growth failure.
Nursing care focuses on medication adherence, nutritional support, psychosocial support, and education.
Peptic ulcer disease is chronic mucosal ulceration in the stomach or duodenum, with primary ulcers often linked to Helicobacter pylori.
Secondary ulcers occur due to stress or medications like NSAIDs.
Clinical features vary by age, and diagnosis is via endoscopy and H. pylori testing.
Treatment includes acid suppression with H2 blockers or proton pump inhibitors, antibiotics for H. pylori, and mucosal protectants.
Nursing care emphasizes medication adherence, dietary counseling, and stress management.
Turning to hepatic disorders, hepatitis refers to inflammation of the liver caused by viruses A, B, and C, or metabolic, toxic, immune, or vascular causes.
Hepatitis A is transmitted fecal-orally, causes an acute self-limited illness, and is vaccine preventable.
Hepatitis B is transmitted parenterally, with a risk of chronic infection, especially when acquired perinatally. Universal vaccination is recommended.
Hepatitis C is bloodborne, often chronic, but newer antiviral therapies offer a cure.
Diagnosis involves serological markers like antigens, antibodies, and viral load.
Management ranges from supportive care to antiviral therapy, depending on the type.
Cirrhosis is end-stage liver disease with fibrosis and impaired function, leading to complications like ascites, variceal bleeding, and hepatic encephalopathy.
Management includes nutritional support, managing complications, and liver transplantation.
Biliary atresia is a progressive obliteration of bile ducts, leading to cholestasis, cirrhosis, and liver failure.
It presents with persistent jaundice beyond 2 weeks, pale stools, dark urine, and hepatomegaly.
Diagnosis involves labs, imaging, liver biopsy, and intraoperative cholangiogram.
The Kasai portoenterostomy is the primary surgical treatment, with best outcomes if done before 8 weeks of age.
Many children eventually require liver transplantation.
Nursing care includes family support, nutritional management with fat-soluble vitamin supplementation, and education on complications.
Across all these conditions, nursing and family-centered care are pivotal. Accurate fluid balance monitoring, pain assessment, nutritional support, and education on disease processes and emergency management are universal priorities.
Psychosocial support is also essential, addressing the emotional burden of chronic illness, growth delays, and hospitalizations.
Collaboration with multidisciplinary teams and community resources enhances care continuity and family coping.
To wrap up, pediatric GI conditions are multifaceted, requiring a deep understanding of developmental physiology, immunology, nutrition, and complex pathophysiology.
Management is nuanced, balancing medical, surgical, nutritional, and psychosocial interventions. Early recognition, appropriate intervention, and family-centered care improve outcomes.
We hope this episode has unpacked some of these complexities and provided insights and clinical pearls for those managing these challenging pediatric conditions.
Thanks for joining us today. We look forward to exploring more topics with you in the future.